So the majority of dogs with lymphoma will actually be clinically well. Most times families will actually notice enlarged lymph nodes at home, and that's the first presenting sign, but they can be pretty nebulous just depending on where it starts. But the majority of dogs will have peripheral lymphadenopathy. So that's the most common thing. And a lot of dogs actually get picked up by groomers or boarding facilities or sometimes even at daycare just because they're being handled so much. So lymph nodes are definitely hands down the number one thing to tell families to watch for. Generally anything that you would do for a typical wellness workup. So a full CBC and chemistry panel, a urinalysis if you're able to, just to get a general baseline of general well-being and how their organ function is. Sometimes we will pick up different abnormalities on a CBC differential, like an elevated lymphocyte count or thrombocytopenia. Occasionally we'll have neutropenic patients at diagnosis. It's not typical, but it's nice to have a baseline to know where they're starting. If they can have imaging done, or if a family wants to have it done, that's certainly nice to have, but it's not a requirement. The most important thing, if they have an enlarged lymph node that you can sample for cytology, that should definitely be done before referral. So these are the ones that sometimes can be tricky. A lot of times dogs that have hypercalcemia also have a mediastinal mass. That's a pretty easy thing to check for. So when we talk about imaging, chest x-rays are always one of the things that we get asked, do we absolutely need them for lymphoma? The answer is no, but if there is a suspicion that we're dealing with that cancer, or you can't find anything else on exam that would support it, that would be the easiest place to check. The other thing is, if there's a hypercalcemic dog and you think it's lymphoma but you can't confirm it, also make sure that you do a rectal exam, because sometimes we're thinking lymphoma and we're actually dealing with an anal sac tumor. So PAR and flow cytometry both look at clonality, basically trying to decide, is this truly lymphoma and expanding from one cell population, or is it heterogeneous like a reactive lymph node would have? And specifically which type of lymphoma we're dealing with if we're able to confirm a diagnosis. They test for the same thing, but they are run on different samples. Flow cytometry needs to be done on a fresh lymph node sample that you collect similar to cytology, but place in a liquid flow media tube. Those usually have to get to the lab within 24 to 72 hours because the cell viability can drop off. PAR can be run on slides, so cytology slides that are saved can be counterstained. So it's a nice option to have if you can't collect flow, or if an owner isn't sure that they want to do that test, but they want to add it on at a later date. It just has a longer turnaround time. Typically we see either B cell, B as in boy, or T cell, T as in Tom. Those are the two most common, with about 85 to 90% of dogs having B cell disease. There are some breed predispositions that we see. Boxers have a very high predilection to T cell lymphoma, and many of them will be hypercalcemic. So sometimes that's an easy thing to spot. Golden retrievers are about 50-50. Same thing with pit bulls and Rottweilers, usually have B cell disease. A lot of the Japanese breeds tend to have T cell. So it's not a hard and fast rule, but sometimes it can help you guide what diagnostics you might need to do. Generally, if they're feeling poorly and they can't get to an oncologist fast, so over weekend times, holidays when those come up, or if a family is debating what they want to do, but the patient is declining in the interim. We will never fault any clinician for starting steroids if it's for the benefit of the patient. If they're stable enough and they're feeling fine and it's an incidental lymphoma, then it's best to wait. But lymphoma can change quickly, so it's a conversation that we always have with the family. Starting steroids can skew diagnostics or make it hard for us to get samples that are useful. So anytime you can wait, that's great. But if you can't, it's really based on how well that patient is feeling. Other than complicating diagnostics, not typically. It depends on the size of the dog. If we're talking about anything that's 15 kilograms or over, we'll generally dose on a body surface area, so somewhere between 30 and 40 milligrams per meter squared per day, which usually ends up somewhere in the 1.5 to 2 mg per kg per day range, which is how we dose the smaller patients, just so that they're not getting into a toxic range where they're at risk for GI ulceration. So it's based on a conversion from kilogram weight. So the most important thing, depending on what you weigh your patients on initially for scale weight, is if you're using pounds, make sure that you convert it first and then go to your body surface area. There is a calculation that you can use, but most of us keep a metered squared chart. Plum's formulary, I believe, has one in the back of it, or VIN also has a good resource. So not all, it's still our standard, pretty much gold standard protocol for the majority of dogs, but T-cell dogs are probably the exception. We do find that some drugs work better than those in the CHOP protocol, so we may use a modified version or use a completely different protocol overall. A little bit of it is clinician dependent, a lot of it is family driven based on what their goals are, whether or not financially and time-wise they can afford a CHOP protocol, or if it's appropriate for the age of the pet. Those are all factors that go into it. But as a standard rule, CHOP is what most families will come in prepared for, and then we tailor it based on what they're looking to do. Other than steroids, not so much. It really just depends on the symptoms that a pet is having. Lymph nodes are not essential, and if they're growing slowly, like some lymphomas can do, then some dogs may be able to go without treatment, even steroid treatment, for a period of time, and then be palliated with steroids if they need it. There are some other oral medications that can be used, but they're not cost effective, so unless a family is really interested in doing something non-standard, prednisone is pretty much the most palliative thing that we use. That is a little bit clinician dependent and how sick they are. So the way I was trained specifically, if a family is all on board and we're using a CHOP protocol, I will typically induce a patient with LSPAR at the time of their first treatment. That can make them feel poorly if you're combining drugs. So it depends on how much disease they have, whether or not they're feeling good enough to tolerate a combination treatment to start. So not every dog will have it. We can use it on an emergent basis. So LSPAR is a nice drug to have on hand if we're running into a weekend and it's a patient that's declining. We've confirmed lymphoma, but we don't have enough time to get them to an oncologist to safely start. LSPAR can be used as kind of an induction treatment because it's given subcutaneously, so it's a lot easier to manipulate than some of the intravenous drugs. Typically the same that you would for any other chemotherapy drug. So the side effects can be similar. Nausea is the biggest thing that we worry about. So I always recommend, even if they're feeling good and you're just giving LSPAR, to send them home with an antiemetic just to have on hand. Even if they don't need to use it, it's better safe than sorry. LSPAR with the first dose, we typically don't see reactions. Dogs can have more than one dose over their lifetime. There's no technical cap on the number. It just depends on whether or not they develop an allergic reaction. Repeat exposure can make them at higher risk for it. So first time dosing, we usually don't pre-medicate. Anytime they see it second time or over, we always pre-medicate with at least Benadryl, sometimes a dose of Dex SP, depending on what medications they're on and if it's safe to. And if they have a reaction at any point, that's the last dose they ever had. So we won't repeat it beyond that unless it's an absolute dire emergency. Typically the same that you would for any other chemotherapy drug. So the side effects can be similar. Nausea is the biggest thing that we worry about. So I always recommend, even if they're feeling good and you're just giving LSPAR, to send them home with an antiemetic just to have on hand, even if true tumor lysis syndrome, we don't typically encounter. It's reported in people, but even at that, it's rare. It happens with naive lymphomas, so newly diagnosed patients with a very heavy tumor burden, even if they're feeling well. These are the dogs that have massive lymphadenopathy, massive visceral organ involvement, that if they have a really sensitive form of lymphoma and all of their cells die off quickly from the first treatment, which is what we want for cancer control, that can make them feel poorly from all the toxic exposure. So things that we watch for, If it's going to be a true acute tumor lysis case, it can happen within the first couple of hours of treatment. We usually see more mild cases. So the dogs that have really heavy tumor burden that we're treating, even if it's just Elspar and prednisone, I warn those families. If within the first 24 to 48 hours of treatment, they're seeing that they're just really dumpy looking, but their lymph nodes are practically non-existent from what they can feel, chances are they have a mild case. Most of them can be managed with subcutaneous fluids, maybe IV fluids, depending on how dehydrated they are. The worst cases can have really severe electrolyte imbalances. So those are dogs that may come in with arrhythmias or collapsing. They can be hyperkalemic. It really depends. But most of the cases that we see on the clinical side are mild enough that families, if they're appropriately prepped for it, can give medications at home to get them through the worst of it so that they don't end up in the hospital. So generally speaking, for B-cell lymphoma, and that's the most common type, for families that are interested in pursuing treatment, we always recommend that we type them so that we can make the most specific protocol and give them the best prognostic information. But being that that's the most common, if they're treated with a standard CHOP protocol, the average survival is about 10 to 14 months, with about 20 to 25% of patients living 2 years or longer before relapse. T-cell dogs can have the same upfront response. We tend to see them relapse faster, sometimes as they're approaching the end of their protocol or right after we pull them off of treatment. So it's nice for families to know that upfront. Not that they won't treat, but sometimes we will adjust their protocols or choose maintenance protocols after, just because we know that their remission times can be a little bit harder to control. But generally speaking, 10 to 14 months if they're treated with a standard protocol. Steroids alone, typically 1 to 2 months. I've seen patients up to a year on steroids alone. It really just depends on how tolerant they are. Lymph nodes are not essential. How much cancer they have is not the issue. It's how well they can compensate for it.